Hi everyone, this is Ashley Churchward from North Shore-LIJ Health System. Thank you for joining us this afternoon for our webinar about individualized breast cancer treatment options. I am joined by Dr. Janna Andrews, radiation oncologist at North Shore-LIJ Cancer Institute. So with that, I'll hand it off to Dr. Andrews to tell us a little bit more about yourself.
Good morning. Thank you so much for joining us today. This is actually our first Google Hangout for North Shore-LIJ, and today we're going to talk about an article that came out in the New York Times back in December about breast cancer treatment. Just a little bit of an introduction for myself. For those of you that don't know me, my name is Janna Andrews. I'm a radiation oncologist. I've been in practice for just under about 10 years. I recently joined the North Shore-LIJ system about a year ago. I moved back to New York about 5 years ago, and prior to that I was actually the breast cancer specialist at Indiana University. I should say breast and sarcoma specialist at Indiana University, and that's really where I grounded a lot of my knowledge about breast cancer treatment. So thank you so much for joining us.
Thank you, Dr. Andrews. Can you start a little bit about talking about the recent New York Times article and some of the schools of thought that were presented about breast cancer treatment?
Sure. So as I mentioned, there was an article that came out in the New York Times in December. I think the article was actually titled "Long Radiation Treatments Unnecessary in Many Breast Cancer Cases." So a very loaded title, which is great because it probably caught a lot of people's attention. What the article is referring to is a little bit of a shift that you're seeing in radiation in terms of breast cancer treatment. Traditionally, breast cancer would be treated with a 5 to 7 week regimen, or what we would call more traditional fractionation, a smaller fractionation daily. There were 4 trials that came out looking at using a shorter regimen, and what they demonstrated was that the shorter regimen, which could be anywhere from 3 to 5 weeks, was not inferior to the more traditional regimen. We can talk about the Canadian trial where they looked at women, and what they found was that when you compared the shorter regimen to the longer regimen, the 10-year risk of local recurrence was essentially equivalent. I think 6.2% versus 6.7%, so we consider that to be pretty much the same. And the cosmetic outcome was pretty much equivalent as well. So that being said, what you saw was more radiation oncologists shifting to the shorter regimen. What the article in the New York Times points out is, why hasn't there been more of a shift? I would say guidelines actually came out in 2011 that supported the shift even more, and it looked at women ages 50 years and older with early stage breast cancer, and it supported the use of the shorter regimen over the longer regimen. In 2008, roughly 10% of these women were receiving the shorter regimen. By 2014, roughly 35% of women were receiving the shorter regimen. But I guess the question is, why haven't there been more? And all I can say to that is change takes time. Nearly 2/3 of women that they reported on received radiation therapy, but many of them still received the longer regimen. And when you look at the total cost, or if we actually look at the projection of the total cost for breast cancer treatment, if you look at 2020, the estimated total cost for breast cancer treatment will be close to $160 billion. In relation to this regimen, the shorter regimen is almost $3,000 less than the longer regimen, so that is a significant difference. And so between cost and convenience for the patient, it does make sense in the appropriate patient to offer this as a treatment option.
Great, thank you, Dr. Andrews. And based on your experience, can you talk a little bit more about longer versus shorter treatments, and more about the importance of individualized treatment?
Sure. So what I would say is that I think I can speak for my colleagues and myself. I think that we are supporters of the shorter regimen. But if you look at the New York Times article, I think Friedman made some very good points in terms of if you've been doing something for 25 years, 30 years, and it works, and you have a good cosmetic outcome, you may be a little bit slower to actually change your practices. What I would also say is that, it's one size does not fit all, and so it is great for myself to be able to sit down with my patients and actually offer them treatment options. So if a patient is a good candidate for either the shorter regimen or longer regimen, I go through each regimen with that patient and I discuss the data, and depending on what their lifestyle is or whether or not they are more data driven, so I let them make that decision. In terms of why wasn't implemented earlier or sooner, I think if you think about the evolution of breast cancer treatment, from the days where all women were being offered mastectomy, and then we found out that you could actually offer a lumpectomy with radiation in an effort to help decrease the risk of local recurrence, and that could give you similar results to a mastectomy. We've made great strides. Now, if you look at it in terms of radiation, I would say that in the 80s, you probably really weren't able to offer this shorter regimen just because our technology just wasn't as advanced, and so potentially the cosmetic outcome would have been more detrimental to the patient. Yeah, that's pretty much what I would say, is that basically as the technology improved, it gave the patient more options. So they can either have whole breast radiation with the shorter regimen, the longer regimen. Now they can actually have whole breast radiation where they are either lying on their backs or they are prone, meaning laying on their stomachs, to pull the breast away from the chest wall and decrease dose to the heart and the lung. And potentially they can even have something called partial breast radiation, where you actually just treat the tumor bed, basically just where the cancer was, risk of recurrence right in that area.
Thank you. And I know you touched on this a little bit, but can you talk a little bit more about how you and your colleagues evaluate patients for treatment here at the North Shore-LIJ Cancer Institute?
Okay. So I think going back to the one size fits all, I think it's important to keep in mind that the mantra that one size does not fit all. And so when we are evaluating patients, depending on your health and your overall stage, you may or may not be a candidate for the shorter regimen or longer regimen, or potentially your lymph nodes need to be evaluated. When I'm evaluating a patient, I'm looking at the whole patient. So I'm looking at your family history. I'm looking at how many children you have, your past medical history, whether you have a prior history of cancer. I'm also looking at your pathology. So what type of surgery did the surgeon perform? When the surgeon removed the tumor, was the pathologist satisfied that all the tumor had been removed? Were the lymph nodes assessed? And if so, how many lymph nodes were removed? And then also when the pathologist is looking at the tumor, was the tumor what we call estrogen or progesterone or Herceptin positive? So we take all those things into consideration before we actually make a definitive treatment decision or offer different treatment options to the patient.
Great, thank you. And I know we have a few questions here that we've gotten from viewers. Before we start with those, is there anything else that you wanted to kind of talk about, in reaction to this article, or about the evolution of radiation treatment during the course of your career?
I mean, I think if you look about the evolution of radiation in my career, I would say that historically we were more aggressive, at least with locally advanced cancers. We treated more fields depending on whether or not lymph nodes were involved. If you look at early stage breast cancer treatment, I think we have benefited in terms of moving away from the one size fits all mantra and really individualizing treatment for the patient. A lot of barriers to treatment depend on convenience, and so with the shorter regimen, it is a more convenient option for a woman who may be working and may not be able to take 5 to 7 weeks off of work, or just may not be able to make that time commitment because of her family obligations. We are offering prone treatments as well. I should go back. In terms of how we even do the treatment planning, we have advanced in terms of all of our treatment planning now is CT based. So what that allows us to do is pay attention to the different critical structures. And so for breast cancer specifically, we're thinking about lung and we're thinking about heart if it's a left-sided breast lesion. When we do the CT-based planning, we are able to contour each of those structures. Every organ in the body has a tolerance dose to radiation specific to that organ. And so we're able to tell the computer when we're generating the plan that we want to minimize dose to the heart or to the lung while giving a nice even dose distribution throughout the breast. One thing that I can say about the shorter regimen is that it's still, the data has not yet been finalized in terms of whether or not the shorter regimen, because it is a larger dose daily, whether that offers more cardiac toxicity compared to the longer regimen. That's what we're looking at now. As of now, we would say no, but we need longer follow-up and longer follow-up data to actually make a definitive statement about that.
Great. So with that, we'll start with some of the questions that we have here from our viewers. First, what value should patients put into these studies, like were in the New York Times article? How much, credence should they have in them?
Well, I think that the New York Times article was great. I posted it on my Facebook page. I think that any article that raises cancer awareness is a bonus, right? It has led us to this discussion today, and so I think it has been extremely beneficial. Now, I do think that the title is a little bit heavy-handed just because it implies that some doctors are not doing the appropriate treatment for their patients. But what I would say is that the title probably caught more people's attention in terms of why doctors are slower to adopt the shorter regimen. I would just say that change takes time. What the article did mention was that in Europe, compared to the United States, in Europe and Canada, they have been much more successful in terms of adopting the shorter regimen, but I think it should also be the 4 trials that were done, randomized trials that were performed comparing the more traditional regimen to the shorter regimen were actually done in Europe and Canada. So potentially that is why they are early adopters compared to the United States. I think that between 2008 and 2014, to go from 10% to 35% in the appropriate patient population, I think is a tremendous increase, and I think you'll see more. So I think the New York Times article is great, maybe slightly misleading, but I think it was a great article.
We also have to ask, I don't know if my doctor considered a shorter treatment regimen for me in particular. Should I ask my doctor about this?
Sure, I would say there isn't a question that you can't ask your doctor. And so if you were interested in the shorter regimen, or if you weren't offered the shorter regimen, it is a good idea to ask your doctor just to understand why and to find out why potentially you weren't the appropriate candidate. As I stated before, it's ideal, or the guidelines supported in women 50 and older with early stage tumors that don't have lymph node involvement. That being said, it's not that we can't use it in other patients that don't necessarily meet that criteria. It's just that the data has not matured to this point to support those different patient populations.
Another viewer said, my mother had radiation treatment in the 80s. How is radiation treatment different now?
So radiation has, advanced tremendously since the 80s. I would say in the 80s we were not using CT-based planning. So the treatment and the treatment planning for breast cancer was more basic. In the 80s, we weren't necessarily able to shape the dose. And so what you would have are basically two beams, one coming from the left side of the chest, one coming from the right side of the chest to treat the breast. But whatever tissue was in the way, we weren't necessarily able to block any lung tissue or block heart tissue, depending on whether or not it was a more locally advanced breast cancer, and we had to add a nodal field. These treatments were just much less advanced, and so the side effects and the toxicity potentially could have been more.
We also have, I heard radiation treatment can lead to burns and scarring. Is this true?
So in terms of radiation leading to burns and scarring, I'm glad you asked, because I think it's one of the things that makes patients very nervous to come in for radiation. One is that they expect, and two, they just hear horror stories about the potential side effects. So for breast cancer treatment specifically, radiation can cause some tanning or a sunburn type reaction just in the treatment field. So just to the breast that we are treating, the tanning or the sunburn reaction will heal, it will go away. Potentially the hyperpigmentation or the tanning can take months to resolve. Scarring is caused, radiation does cause scarring in the breast, or fibrosis, as we like to call it. What you may notice is that if a patient is looking in the mirror, they may notice that their breast that they're getting treated to appears smaller than the opposite breast. That is a difference that is noticeable to the patient. It is likely not a difference that would be noticeable to anybody looking at the patient or walking down the street and seeing the patient. So it's more of a noticeable difference personally, potentially, than what anybody else would notice. But radiation does have its side effects. Ideally, you will get through your treatment with no side effects, but you should still know that there are some potential side effects that may make you uncomfortable in the short term.
We have some more questions that have come in. Who would you think that the longer radiation treatment suits, if anyone in general?
So I think the longer radiation treatment is tried and true. The data that we have on that is substantial, 20, 30 years worth of follow-up data. I think that if you are a data-driven person and you like numbers, then potentially the longer regimen is for you. I know that currently right now, although there is data to support using the shorter regimen in patients with lymph node involvement, we are much slower to adopt that, just because there are different critical structures that would potentially be in the field, such as the brachial plexus, that is a nerve bundle that we are not sure how it would react to the fractionation for the shorter regimen. But again, one size does not fit all, and so when you're seeing your physician, they are going through all of your criteria, they're going through all of your past medical history, they're looking at your tumor, and it should be a discussion amongst you and your physician as to which treatment option is the best for you. And if you're interested in another treatment option and it is not the best for you, then it should be explained to you as to why.
The other question just come in. For women who are getting the longer breast cancer treatment, you touched upon this a little bit. They should discuss, with their doctors their options. If the doctor does suggest the longer treatment option and they want the shorter, is there an ability for the patient to decide to switch? Would you recommend that from a medical perspective?
Is there an ability for the patient to try to switch once they're on treatment, or if they're seeing a different physician?
Either or. Once you started treatment, is it possible, you're a few weeks into a week or so into longer treatment, say, I would like to do shorter, or started with one physician and say, I want a different course of treatment, I'm going to go to another. What is good from a medical perspective and what probably isn't the best for a patient's treatment course?
So I think the first thing that we should touch on is getting second opinions. So we as physicians do not take it personal if you want to get a second opinion. It is your right. If you are not comfortable, you should do your due diligence. At the end of the day, you are the only one that has to be happy with your choices, your treatment options, and your outcomes. So if you aren't necessarily being offered a treatment option that you think you may be a candidate for, definitely get a second opinion, and you potentially may be right, or you may hear confirmation as to why you're not an appropriate candidate. Ideally, once you have started your treatment, it is not a good idea to switch regimens. There would have to be a lot of calculations and basically radiobiological calculations made to figure out what the dose difference is between the two different regimens. So when you choose your treatment regimen, or when a treatment regimen has been discussed with you, you really need to commit to that once you've actually started your treatment.
Great, and that was our last question. So, thank you, Dr. Andrews, for your time this afternoon, and for everyone who's watching, thank you for your time as well during your busy lunch hour. If you come up with additional questions for Dr. Andrews, please feel free to send those to us. You can use Twitter using the hashtag NSLIJCancerChat. Actually, I've just seen one more question come in. So we have one more last minute.
Okay.
Are there any advancements in breast cancer radiation treatment, recently that patients should be aware of?
Advances. I think we've been discussing a lot of. Apologize. We had to switch the mic. Mm-hmm. I think we've been discussing a lot of the advances in this Google Hangout. I think in terms of advances, many more facilities are doing prone breast irradiation for the proper patient in order to decrease dose to the lung and the breast tissue. So prone breast irradiation is where a patient lies on their stomach and the radiation is given that way. Today we just treated a patient with partial breast irradiation, and that can be either given through a device that's inserted into the tumor bed, or with external beam irradiation, and that's an abbreviated course of radiation typically given over 5 to 10 days, once or twice a day. That is a great option for the appropriate patient. For a whole breast radiation treatment, again, you have the shorter regimen, which could be anywhere from 3 to 5 weeks, versus the longer regimen, which is 5 to 7 weeks. I think it's important to note that even though these 4 trials were performed, the trials showed non-inferiority. So it didn't show that one regimen was better than the other, but that the shorter regimen was not inferior to the more traditional regimen. So I think those, just to name a few, are some of the advances we've made, on top of how we plan our radiation using image guidance with CT-based planning, and our planning systems have also improved, and so we are able to modulate the dose or shape the dose away from the lung and away from the heart as well.
So for a second, thank you everyone for your time this afternoon. Thank you, Dr. Andrews.
Thank you.
Like I said, if you have any questions, you can reach us via Twitter using the NSLIJ Cancer Chat hashtag. You can also visit our website at NorthShore-LIJ.com, and you can contact the North Shore-LIJ Cancer Institute directly at 855-858-8550. Again, thank you for your time this afternoon, and this was us at North Shore-LIJ wishing you a very good, happy afternoon. Thank you.
Thank you.